I'm actually coming. Before coming to UK, I've been in Pakistan working as a public health practitioner for about 10 years. And my main role in that was to look at the data and see where are the, where are the adverse health outcomes and where we need to develop some intervention and promote health in those communities. So we would look at the data, design, and then implement that intervention, and then we'll monitor and evaluate, see whether intervention is making any difference to their health equity or not. So that's the kind of work I have been doing. And when I moved to UK, I started as a digital health researcher. I started working on digital data collection tools to generate patient-generated health data, and working on their validation, and also exploring how the information collected from these tools can be utilized for self-management or for clinical decisions making. So not only using this data for research purposes, but also exploring how that data, same data, can be used for other purposes. And through the ARC support, so I've been working with Sabine on digital health inequities, and we are developing a program of work around it. And Pain Manikin, we use it as an example to see how we can improve this tool further, and perhaps using that as an example and apply it across other tools that we're working with, or Sabine or other researchers they're working with. So we all know that how we perceive technology as a very positive thing, and it tries to connect or links a healthcare system with individuals, and individuals having diverse needs, and they are connected through these devices, and through these devices they can connect to health systems. So the assumption is that everyone would have equal access to technology, so they will exhibit equal health outcome, but that's not the fact we know. So there are people who may find a barrier over this bridge, and they may exhibit, because of that barrier, they may have limited access to health services, and then they will have some health equity issues. So how, so how basically we are describing digital health inequities. So these are unfair and avoidable differences in health outcomes, which are created or exacerbated by introducing digital technologies. So you can clearly see here that it stems from the concept of health inequalities. So we are again having focus on health inequalities and see what impact our technology we may have on the existing health inequalities, whether those health inequalities are we able to address them, or are we actually creating or exacerbating the existing inequalities. So I'm going to now give you a bit of a background about the work that we have been doing. So our work is mainly around pain assessment. So it's quite recognizable now that chronic pain is increasing across the world, and it is now becoming a global public health issue. And there are many organizations who basically speak for patients, or raising the voices of patients. They are saying that management of pain is still suboptimal, despite the fact that there is a huge focus on interventions and developing tools so that this can be pain can be managed in a better way. And part of this problem may be that how pain is actually assessed. The Chronic Pain Policy Coalition, so they have been saying that this precise scale for chronic pain in England is still unknown. It means the way we are actually assessing or measuring pain, so we need to think about them. So kind of things that we know already, that that these tools, the existing pain assessment tools, they are not adequately capturing the different pain aspects, and because of which prevalence of pain is still unknown, and how it changes over time, it is also unknown, and the impact it leaves on a person's life, that is also unknown, because all these things changing, they change over time, and we need to be able to capture those changes changes while there's a change in pain. So, and there's also increased recognition that um, um, since pain is a subjective experience and it is also very complex, that needs to be collected through directly from a broad range of patients so that we can understand how prevalence is changing as their characteristic changes or as the situation changes. And we think that digital pain mannequin, because how it looks like and how it offers ease of use, it is a possible solution to these problems. So here you, on the right side of the screen, you see uh, a screen recording of the app. So here, sorry, I'll have to go back and play this video here. Yeah, so you will see this is the current version of the app, and the purpose of using it to collect research data. So you have seen at the first that there was instruction written in English, and then there was a single pane written question, and this is the mannequin. So it's a two-sided view, front and back, and with your finger you can first select the intensity of the pain, and you can start drawing on the mannequin. So that indicates the extent of the pain and intensity of that specific location. So it is actually giving you two information with single action of your pain drawing. And once you have completed your pain drawing, so wherever you have pain, you are able to describe your pain by using this free text. So this is the tool that we've been currently working on, and I may refer to a few bits of it when I progress with my talk. So here I'm perhaps going to present an hypothetical case just to show and demonstrate at what points a person may face a particular kind of barrier or challenge that may likely have an impact on this person's health equity negatively. So imagine there is this person, Amr Salim. He is South Asian by background. He's male, age 63, and he has been experiencing pain for more than a decade. It means that he's been receiving treatment, but it's that treatment is actually not working for him for whatever reason, but pain is not managed for him adequately. So I'm going to take you through a hypothetical patient journey, but not entirely hypothetical. Definitely, I have developed based on the information we have collected from patients and from healthcare professionals. So there's some sort of fact in this hypothetical case also. So life between Amr Salim's house and hospital. So we know a healthcare professional who sits in the very busy NHS hospital is very important, but he has very limited time. So he interacts with patient, and that interaction is mostly 10 to 15 minutes when we would try to understand what has been going through with Amr Salim's pain condition over the last few months. And so the first thing that a doctor may face or a patient may face, that's communication. So definitely English is the language where they communicate. And if they use interpreter, so there is still a challenge in understanding language. And also there are certain pain terminologies which might not be understood by Amr Salim because of his cultural background. He might not be aware of, for example, pain quality, which is quite easily understood in white British people, but not easily understood by these people. So that means this is the barrier potentially for them. And then what's happening? Okay. So definitely doctor wants that he has enough information with him so that he can develop a treatment plan for him, and then making sure that his pain condition is managed appropriately. So he may use, he may advise Amr Salim to use this questionnaire, which is written in English and has a mannequin on it. This is very famous questionnaire used for pain assessment called McGill Pain Questionnaire. And he may hand over, or he hands over this questionnaire to Amr Salim and say, okay, you go back to your home and fill this questionnaire daily, so that once you come back to me, I would have enough information, without recognizing or realizing that there might be some challenges here also. Sorry, so there's some animation error here, so but I can read that for you. So definitely here again, language is the problem. And also the time it takes to complete a questionnaire. So doctor has actually asked him to complete daily. So and there are evidence that suggests that it takes about 7 to 10 minutes to complete this questionnaire once. And also, if you are completing these questionnaires, then you need a place to store them. And if, for example, you lost some questionnaires, then definitely you are losing information. And also, when arm wrestling goes back to doctor, then definitely there might be, so how doctor is going to summarize that information and use it for the purpose of making clinical decisions. Now, thinking about it again, there is another part of life which is very important for arm wrestling, which is his social life, his family life, and how he interacts with his family members. So there are many cultural aspects associated with it. So if I think about South Asians, so there's likelihood that they will not talk about pain, maybe because to preserve their image of masculinity, and also thinking, okay, he's a man, I should not talk about pain. So that might be the reason he's not talking about his pain with his family member. So there's definitely a cultural influence that how he would perceive pain and how he will talk about his pain and whom he will ask or he will speak to in terms of seeking help. So there's a tendency that he will hide things or he will not talk about it. So there's a negative disclosure behavior associated with it. If you try to see how culture has an influence on his on how he perceives and manages and talks about his pain. Now going back to doctor. So now he has information. He goes back to doctor, and then definitely, like I said, I mean, it will be hard for doctor to make an inference because there was already some barrier for arm wrestling to understand these questions and completing them on daily basis. Then he introduced this tool, this amazing tool to him. Now we know as a researcher this is an amazing tool, but for him whether this is amazing, we need to consider other things like there is existing lack of distrust in these digital health tools. So that's a big problem we need to think about. There's a lack of digital literacy we need to think about, and again, language barrier is still there. So these were type of barrier with which arm wrestling might have faced while going through this typical patient journey. Just summarizing kind of difficulty he would be going through, difficulty in pain communication, not only in terms of language, but also the terminologies that which are actually, subject specific terminology, I would say. So for example, pain related terminologies. And challenges in completing these questionnaires is always a problem. And if we use any digital tool, then there are definitely many aspects associated with digital tools. For example, lack of trust, access, and literacy. And certainly providers bias. I mean, this is also important to recognize that, I mean, there is already a recognition within the literature that provider would have some bias. And I think so. It may be because of the limited information they have. So based on the information they get or they understand from the patient, so they take decisions. And at the end, there's certainly a bias. But if you have right information or correct information or enough information about the patient, then definitely you're likely to address this. So coming to this, so there are two bits of work that I'm going to talk about. First one is digital health equity impact assessment of the digital pain self-reporting tool and cross-cultural acceptability of these tools. So before coming to this, I mean, I think so there is a very important question that we need to ask first. So I'm here perhaps promoting NIHR's Include project, where they have worked through ethnicities, ethnic minority groups, and see, okay, what kind of questions we need to ask, because I think these are very important questions. Who should be in the trial? So definitely those where there are existing health inequalities, we should be able to recruit people from that group so that we can understand their perspective. So who should be in the trial? Will the people identified respond to the treatment differently because they have adopted the treatment differently, or maybe treatment itself has a different effect on that person or group? And will the intervention itself make it hard for some people to involve? So basically I have just now, kind of modified this set of questions and make it more suitable for our research. So who should be involved in equity impact assessment of the digital pain mannequin? So definitely you would have that question in mind, that whom should we go after and ask, okay, what are your difficulties and how, what solutions you have in your mind so that we can implement them. So, and have the people identified responded to the treatment differently, and with the digital pain mannequin itself make it hard for some people to be treated optimally? It's again, for example, if in the treatment pathway and care pathway, if we introduce this tool without recognizing that some people would have challenges with using this technology, then definitely we are actually adding an additional layer of barrier, because they might not be comfortable using this technology. So what we did for health equity impact assessment, so our team at University of Toronto, they have developed a digital health supplement of health equity impact assessment. So that's the tool existed. I guess it was first developed about a decade ago, and main purpose of that tool was that policymakers should use this tool to identify barriers and develop mitigation strategies so that those barriers could be addressed or reduced or mitigated. So this team at University of Toronto, they have actually developed the digital health supplement of this tool. And we collaborated with them and we tested it with digital pain mannequin work. So this is the process, and I'm not going to talk about each of them in detail, but we'll tell you through examples, okay, what we have achieved or what came out from all of these steps. So first one is scoping, where you try to identify, you ask that question to yourself, okay, which are those groups we need to work with, where the health inequalities are existing. And then you will identify potential impacts, both positive and negative, of using that technology. And then you will work out mitigation strategies by working with that same group who is helping you to identify those negative unintended impact, for example. And then you will monitor those strategies and you will disseminate it. So this is dissemination is again is around transparency and communicating your results with your key stakeholders. So first step is, I would say, perhaps the most important one, because here you identify which are those groups you need to work with. So one immediate resource available to every one of us is literature. So we look at literature and see where are pain inequalities. For example, which groups have higher prevalence of pain, and with that prevalence, whether their treatment outcomes are different from other group or from the rest of the country. For example, if we are talking about ethnic minority groups, so how their treatment outcomes are different from the rest of the UK. So we, and there's another aspect that we looked at. It was use of digital devices and resources. So these are two bits we looked at the literature, but fortunately we also had additional source. So we conducted a feasibility study with 104 people, where we asked them whether this tool is feasible for them to report their pain on daily basis. So we looked at the feasibility study data, look at their completion levels, and we found that these three groups had different or less completion levels than other. So these were the reasons based on which we identified these three groups. So that and that's the step, which is a scoping step, which is an important step. So once we have identified, then definitely we started recruited. So but main objective of doing this work was to explore working with key stakeholders, including patients, healthcare professionals, researchers working with these conditions, and healthcare professionals who are providing pain management services. So we basically engaged with all of them to explore potential positive and negative impact of Manchester Digital Pain Manikin on people's health equity, and identifying potential strategies to manage these negative impacts, and then prioritize these mitigation strategies to achieve an overall positive impact of users' engagement. So we recruited participants through social media groups and pool of already consented feasibility study participants who said, okay, so these were those people who consented us that we can approach them if, for example, we are doing any further or future pain mannequin related research. So these were those people. And we conducted 3 focus group, and in total we recruited 15 people who are living with musculoskeletal pain conditions and 13 professionals who are working with these groups. And then we basically, this was actually the starting point of all the focus groups we had. This is very famous model that we all are aware of, social determinants of health. Though here you will not see digital, but actually digital is there in every aspect of or every component of this model. So this was a discussion, this was very helpful in generating discussion, thinking about all the possible factors and asking them that how, for example, age is affecting or might affect their use of technology, and then achieving health services through it or achieving health equity. So I've just given here few determinants and just to show through examples that how, for example, age and associated factors with age can have impact on people's health equity. So if looking at here, so there are definitely some issues related with age. Few are common across all conditions, and few might be specific for the condition that we've been working with, which is musculoskeletal pain. So dexterity is something which is very common, and because of dexterity, people may have challenges in using this technology. Same for memory issues, pain beliefs. So for example, how pain beliefs are associated. People who are in their older age, they think that pain in older age is very normal, so they are likely to not report it. And if they don't report it, then definitely you would not, or a clinician would not have enough data to plan treatment for him, because there was underreporting in older adults. And if you think about sex, so sex, if you look at it, then there are some gender norms in certain cultures. There's a stigma associated with, for example, with females, and then and it goes on. Definitely these are the factors which are associated with these determinants, but we need to understand that how these factors are associated with their health equity. So in that discussion, we kind of listed down all these determinants. And then we explored what are the positive impacts of this technology. And we need to think about that this technology, we introduced or developed this technology mainly to generate a high quality research data. And these were those impacts which were not intended, but participants have said that how this technology can be really useful for them. So for example, they said improving, so if I talk about improving digital literacy and accessibility. So one participant said that the positive impact of this mannequin for older adults, it will make life easier for them because it will be the first place that we will go when we are having our pain. So you can see that how it can likely address the memory issue, because I mean, there's a tool which is accessible to the person and they can go and report their pain. And then better self-awareness of pain and miscommunication. It's one of the participants said it's actually a very powerful support for effective communication with medical professionals, and thinking of people from disadvantaged groups who have difficulty communicating and who get confused or cannot think of all the different symptoms. So since again, it's something that they they really appreciate it, because I mean it's visual also, and it's easy to complete, and you can communicate your pain more effectively, because this is now aiding that interaction which happens between patient and provider. And lastly, this came from a healthcare professional, and he thinks that it has a potential to remove some of the conscious or unconscious biases that clinician might have in hearing how people are describing their pain, because it's a standard way of presenting the self-reported information. So this is how it may likely address the provider's bias issue, because now you have enough information. Now you're looking at the information more objectively and taking clinical decisions guided by that data. So we certainly identified many negative impacts of using this technology. I have just, for practical reasons, I have included only few. So, but these few are again, highlighting some important points. So for example, the first one is negative emotional effect of how pain is perceived culturally. So, okay, pain perception is something that will guide you or tell you whether to report your pain or not. And if that pain perception is guided by your cultural beliefs, then definitely it is different. So like I mentioned before, older adults may perceive pain differently. So they may report pain differently. So you can see that there are multiple factors that may, contribute to one. Then, because there is lack of awareness about pain mannequin and pain terminologies, it may, it is possible that people would be, they would feel excluded, or for example, even if they are sharing data through this tool, to this pain mannequin, that mannequin data might not be correct, because their understanding of pain terminologies might not be correct. And wrong clinical decisions. For example, if there's a pain mannequin report, clinician is looking at it and patient is also looking at it. And if both of them have different interpretation of this pain mannequin report, then it's likely that clinician is going to take a wrong clinical decision. It means it is directly impacting the health equity of the person. So developing a common understanding of the pain mannequin and the information collected on the pain mannequin is important, so that I'm actually talking about shared decision making, and shared decision making is only possible if we have common understanding of the same thing. And these few are, related to digital nature of this tool. For example, there are certain groups who are less likely to use this technology. It means they will remain underrepresented in the research that we conduct, which is what we need to consider. And then few people, for example, ethnic minority groups specifically, and older adults, they have concerns about how data is stored and managed. I mean, there's some trust issue with that. And if you think about those, ethnic minority groups, so there's the cultural practice of helping. For example, a father, for example, is getting help from their kids. So there's a concern of privacy when there's a need to rely on others for support or self-reporting. So these were few negative impacts, both digital and non-digital. So once we have identified these negative impacts, we worked with same people, and we asked them to think about possible mitigation strategies. And in total, we identified 32 mitigation strategies. I'm just giving a glimpse of them. So for example, and we categorize them in 4 main categories. Number 1, facilitate ease of use and accurate pain reports. Optimizing accessibility for potentially underserved group through changes in the app. And then approaches to making the most of the mannequin data and building trust. So if we think about facilitating ease of use, then you are thinking about all these different kind of groups who would have different requirements in terms of reporting their pain more accurately. So for example, at the moment, like I showed you before, there are 2 views or 2 sides of the mannequin. So adding lateral side, left and right side is important if we want people to report their pain more accurately, and thinking about other supporting material and resources which may help them to use this app or tool correctly, which is instructions in video format. I mean, most normally we do that we produce a user guide with pictures and text in it, but people suggested that we should try working out developing instructions in video format so that they can look at and see how to report pain correctly. Then optimizing accessibility. So thinking about those who are not very much familiar or familiar with English language, or they have some difficulty understanding English language, we may offer audio to listen to questions and instructions. And this audio can be in English, or this audio can be in their own local language. Idea is to help them access this app and understand what we are asking them to complete. And then approaches to making the most of the mannequin data. So at the moment, this mannequin data is used for research purposes, but we need to also think that how we can take most from it and what we need to do. For example, one of the suggestions is provide glossary of pain terms, because it's possible, like I said before, when I was giving the example of Amr Sadim. So he because he has a different cultural background, he might not have the same understanding of pain terminologies which a white British person would have. So providing a glossary of pain terminologies would be a nice thing. And about building trust, both in technology and research. So among other suggestions, one was enable users to control what part of their pain report they would like to share and with whom. So sometimes it's family members, sometimes quite obviously the user of that information is clinician. So you can just pick which part of the pain mannequin report you would like to share with doctor, for example, because there are other information in that pain mannequin report which you think is personal and you would not like to share. So you might have seen here in these mitigation strategies, there are about 32, and the example given here, you would see that these are, most of them are culturally guided. So I will come to that later on, that how we can prioritize the mitigation strategy. But the important bit here is we needed to understand that how different aspects of pain are understood differently in different cultures. So we organize, again, 4 focus groups, and the purpose of those focus groups were to explore similarities and differences across ethnic groups in the description of their pain and its reporting, and collecting user requirements for digital pain self-reporting tools using a smartphone-based pain mannequin as an example. So again, we recruited from social media groups and pool of already consented feasibility study participants. And we conducted 3 ethnicity-specific focus group with white British, South Asians, and Black African, and 1 member checking workshop at the end. So that was the 4th one, where we asked from these 3 ethnicity-specific focus group to attend this workshop and validating few findings with them. So coming to differences and similarities, I think so one thing is important to recognize, and it's again links back to the background where I said pain management is suboptimal. So the lived experience of pain is across all these 3 groups were similar. It was very challenging, and no one was happy with the way their pain was treated. And second thing, which was common across all the groups, it was challenges in pain communication. Even people, where language is not the barrier, so they also felt that it is hard, it is difficult to describe the pain when, for example, you are sitting in the consultation for 15 minutes and you have to describe your pain, for example, in first couple of minutes. It's highly likely that you are forgetting many important information which which doctor needs to know. And there were a few very interesting, I would say, differences. For example, if you think about perceived causes of pain, so definitely it was very much guided by people's cultural background. So I'm also from South Asian background. I would say, okay, the kind of spices we eat, or the kind of oil or amount of meat we eat, so that may be the reason of the pain. And people from different ethnic backgrounds, they mentioned the perceived causes of pain, and their attitude towards pain medication. So few would adhere, others would not, for some other reasons. For example, what I can think of, that they don't want to treat these pain medication as something sweet, and they would take it every day. So they were kind of doing self-treatment. So when they are in pain, they are taking it, otherwise they are not taking it. And then, like expected, stigma and gender norms, very common when you try to study pain perception within the cultural context. So these were the key differences that we identified by having focus group with these three groups. And in terms of how we gathered requirement from these three groups, we ask what is important for them in terms of pain assessment or pain reporting, why that is important, and whether that is already included in this app or not. Because the purpose here was to develop that tool which is acceptable across ethnicities, so that later on it becomes it is scalable, and it can be used at a national level rather than with few groups of people. So I have given example here. So for example, they will say pain location is important, and then they will describe why that was important. And then they would again certainly come up with many suggestions. So here, these are 21. I told you before 32 for our health equity impact assessment work, and here we got about 21 requirements. We just class them into 4 different ways. So what are those pain related aspects which are location specific? Again, what are those pain related aspects which are non-location specific? What kind of feedback they would like to receive? And something about look and feel of the app. I'm not going into examples of these, but the main idea here is to tell that there were lots of requirement. That's what normally you will see when you are asking people that what are those things which they think are important for reporting their pain. So so where we actually land in now. So I think so this is the most important thing I would say, because now we know what are those important things that we need to implement, but we also know that resources are always limited, and we need to think very carefully what we need to implement in order for us to take next step. And next step is certainly improving your technology, and then again conducting research and see whether that improved mannequin has created that impact which we're hoping to achieve. So prioritization of user requirements is, largely it sits within, I may be wrong, but the literature I read so far largely sits within the software development domain and project management domain. And both of these domains, they use agile methods, and you must be aware that these agile methods, they heavily rely on iterative and continuous nature of creating a business value. So there's a certain value that you associate with your tool software, and you see that how the repeat prioritization exercises, improving your technology further, is helping you to create that business value. And in our case, that business value is actually creating a positive impact on people's health equity. So naturally, so we had to ask ourselves, who should be involved in prioritization, and how should we conduct prioritization? So I think so how both these questions are very important, who and how. So if we think about equity then we try to answer these questions. So for example, first one is who should we get in touch with? So one approach can be, again, picking patients from your target population group and run that exercise, prioritization exercise with them. But again, you would be limited by numbers. But what we thought, that involving field experts could be a useful thing. So because that researcher or expert would be using a collective knowledge of many patients, and that will be helpful for us to use their knowledge to rate these or to assess these mitigation strategies or user requirements. And for that, we kind of developed a theory of change. So for example, what we want to achieve through it. So we know that this tool at the moment is pain assessment. So how it is going to create value for people in terms of their health equity. So our assumption is, or theory of change is, that we have developed this Manchester Digital Pain Manikin tool. And if we develop it in a way which is offering better engagement, because accessibility is improved, now people are able to engage with it more as compared to before, then we will be able to generate or create more and high quality data about their pain. And based on that high quality, more data about their pain, clinicians would be able to take better clinical decisions, and patients themselves, they would be able to see the perceived causes of pain, whether that perceived cause has actual link with change in their pain intensity, for example, whether if they eat something that really has an impact on how the pain is changing. So with the high quality and more information about their pain, they will be able to take certain decisions or actions. And so if better clinical decisions are taken and self-management practices are improving, then there's a increased likelihood that their health outcomes will also be improved. So here we thought, okay, how we are going to assess value, and we identified two criteria. One is impact, second one is level of effort. And impact mainly is how we describe it. It's again the same like I suggested here in theory of change. More engagement with technology will help take better decisions and guiding themselves to improve their self-management practices, and they will have better health outcomes in our target population. And level of effort would mean that those people who, so if you're talking about technology development or improving this technology further, what kind of or what extent of resources are required to implement that change. So that's the consideration here. And based off these criteria, once we have evaluated all these mitigation strategies or user requirements, we will judge them whether, okay, which one to move forward and which one to dismiss at this point. So this is just one example how potentially we can do that. So here you see impact at the bottom and level of effort here. So we think where impacts are high and level of efforts are low and medium, we are going to consider them for improving our technology further. And where there are level of efforts high or medium, but impact is low, then we are likely to dismiss them. And there are few which we would discuss further with that, group of experts and discuss whether we need to dismiss it or whether we need to consider it. So this is how we are going to prioritize these strategies. Very quickly, I'm coming to end of my talk, hopefully next 2 minutes. So these are all those challenges which I kind of summarized in the beginning. But what I think, how we are going to achieve digital health equity in pain management. So there are 3 aspects. One is improving accessibility and acceptability of the app. I think so this bit can be applied across any other digital tool. Second one is improving pain management outcomes in target population. And for that, we need to think that how pain data can be used to improve clinical decision and self-management. And third one, last but not least, widening participation. So we need to, at one point we are improving the technology, but we need to engage with these communities who are normally, we normally do not take part in research, and there are issues around trust, which I mentioned before. So building trust in research among these communities, these groups, that's very important. And cultural adaptation of the study resources, for example, and this is the kind of work we are also planning, that how, for example, we can adapt participant information sheet, make it understandable for them whom we want to engage or we want to recruit in our study. So it's not only bringing modifications within the app and making that app acceptable to them. We need to think about the context or settings in which we are introducing these tools, and for that we need to, and I'm here talking about the research culture or research settings. All these tools that we use, we need to check with them whether they are making sense to them or not. Sometimes we think accessing these communities are important, but sometimes once you gain access, you realize perhaps access was not the main issue. That might be one, but we need to develop these study resources in a way which are, understandable and preferred by these community groups. So I think so conclude here. And yes, that's right. Yeah. So thanks very much for listening, and I will pass it on to Sabine now.